Welcome to Module 19, Nutrition and Wound Healing. In this module, we will explore the essential connection between a patient's nutritional status and their body's ability to heal wounds effectively. Wound healing is not only a matter of dressing techniques and pressure relief. It is a metabolically demanding process that requires optimal nutrition. Let's begin by reviewing what you will learn in this module. By the end of this module, you will be able to 1. Understand the role of macronutrients and micronutrients in each stage of the wound healing process. 2. Identify the clinical signs and impact of malnutrition in patients with wounds. 3. Assess and interpret commonly used nutrition screening tools and lab values relevant to wound care. 4. Collaborate effectively with registered dietitians and interdisciplinary teams to develop personalized, nutrition-focused care plans. 5. And finally, provide accurate and relevant patient and caregiver education about the role of nutrition in wound recovery, especially in home and long-term care settings. These skills will help you not only prevent delayed healing, but also reduce complications and readmissions. Wound healing is a dynamic and energy-intensive process that requires an orchestrated response from the immune system, skin cells, and connective tissues. Every step of healing, from controlling inflammation to rebuilding tissue, depends on adequate caloric intake, hydration, and essential nutrients. Unfortunately, nutrition is often underaddressed in wound care. Studies show that nearly 45% of hospitalized patients with wounds suffer from malnutrition. This can result in delayed wound closure, increased infection risk, greater likelihood of pressure injury formation, longer hospital stays. As nurses, we are in a unique position to detect early signs of nutritional compromise, whether at the bedside, in outpatient clinics, or during home visits, and intervene appropriately. Let's briefly review how nutritional needs vary across the stages of wound healing. 1. Inflammatory phase. A. Begins immediately after injury. B. The immune system activates, increasing metabolic demand. C. Nutrients like protein, vitamin A, and antioxidants such as vitamin C and E are critical to modulate inflammation and oxidative stress. Second proliferative phase. A. This is where the wound begins rebuilding, forming granulation tissue, re-epithelialization, and new capillaries. C. Here, amino acids, zinc, and iron support tissue repair and collagen production. C. Energy and protein demand increases further. Third remodeling phase. A. This final phase involves strengthening of the wound bed and collagen cross-linking. B. Adequate vitamin C, protein, and calories remain essential to ensure tensile strength and prevent re-injury. A lack of even a single nutrient at any stage can result in poor healing outcomes. Now let's dive into macronutrients, the building blocks of energy and tissue repair. 1. Protein. A. The most essential macronutrient for wound healing. B. Required for immune cell activity, new tissue synthesis, collagen formation, and maintaining lean body mass. C. Recommended intake, 1.2 to 2.0 grams per kilogram body weight per day, and even more for patients with burns, large exudative wounds, or pressure ulcers. 2. Carbohydrates. A. The primary energy source. B. Glucose fuels white blood cells and fibroblasts. C. A deficiency in carbs may cause the body to break down protein for energy. D. Ideally, 45 to 60% of total calories should come from complex carbs. 3. Fats. A. Important for energy density, particularly in patients with high metabolic needs. B. Essential fatty acids help in cell membrane formation and support anti-inflammatory responses. C. Omega-3 fatty acids found in flaxseed, fish oil, and walnuts are especially useful in modulating inflammation in chronic wounds. Micronutrients may be required in small amounts, but they have a big impact on healing. Let's look at the key ones. Vitamin C. O stimulates fibroblast activity and is essential for collagen synthesis. O Also helps in iron absorption and acts as an antioxidant. Vitamin A. O enhances epithelial cell migration and boosts immune function. O especially helpful in patients on corticosteroids, as it counteracts their delayed healing effects. Vitamin E. O protects cell membranes and supports wound remodeling through antioxidant action. Zinc. O required for cell proliferation, DNA replication, and protein synthesis. O zinc deficiency is common in elderly patients and those with chronic wounds. Iron. O critical for hemoglobin production and oxygen delivery. O also involved in collagen maturation. Amino acids like arginine and glutamine. O-arginine improves blood flow and immune response. O-glutamine supports gut integrity and immune modulation. While supplementation may be needed, always assess dietary intake first and avoid overdosing, especially with fat-soluble vitamins like A and E. Malnutrition is a major barrier to wound healing and often goes undiagnosed. Risk factors include involuntary weight loss, reduced appetite, chronic conditions such as diabetes, cancer, COPD, depression or isolation, advanced age or dementia, difficulty swallowing or chewing, clinical consequences of malnutrition, slower granulation and reepithelialization, reduced immune defense, leading to more infections, protein energy wasting, increasing the risk for pressure ulcers, delayed recovery, longer hospitalizations, and increased mortality. Nurses must recognize red flags like loose-fitting clothes, poor oral intake, low BMI, and muscle wasting. Early nutritional intervention can significantly improve healing outcomes and overall patient well-being. As nurses, we are often the first to notice the subtle signs of nutritional risk. Early identification through assessment tools can help initiate timely interventions and improve wound outcomes. Several screening tools are widely used in clinical practice. The Mini Nutritional Assessment, MNA, is ideal for older adults, especially in long-term care settings. It evaluates dietary intake, weight loss, mobility, psychological stress, and BMI to classify nutritional status as normal, at risk, or malnourished. The Malnutrition Screening Tool, MST, is quick and effective in hospital settings. It relies on two questions: unintentional weight loss and decreased appetite, to flag patients for further evaluation. Subjective Global Assessment, SGA, is a more comprehensive tool, typically used by dietitians, but nursing input on history, functional capacity, and physical signs like muscle wasting makes it collaborative. The Braden Scale Nutrition Subscale helps predict pressure injury risk. A lower nutrition score on this scale correlates with greater risk, highlighting the need for nutritional intervention. Remember, no single tool tells the full story. These assessments work best when paired with your clinical observations, changes in appetite, weight trends, and visible signs of malnutrition like muscle wasting or poor wound granulation. While screening tools are a great starting point, laboratory markers can add insight into a patient's nutritional and inflammatory status, but they must be interpreted with caution. Let's look at a few key markers. Albumin, 3.5 grams per deciliter, has long been used as an indicator of protein status, but it is a negative acute phase reactant. This means levels can fall in response to inflammation or infection, not just malnutrition. Think of it more as a chronic marker that may suggest longer-term nutritional decline, particularly if inflammation is minimal. Prealbumin, less than 15 milligrams per deciliter, reflects short-term protein status due to its shorter half-life. However, like albumin, it can be suppressed in inflammatory conditions, which is why it should be interpreted in context. C-reactive protein, CRP, is a direct measure of inflammation. When CRP is high, prealbumin may appear falsely low. Monitoring trends between CRP and prealbumin together can give a better picture. As CRP levels decrease, a rising prealbumin often indicates nutritional improvement. Ultimately, these lab values are just one piece of the puzzle. Always combine them with dietary intake records, weight history, physical exam findings, and wound healing progress to guide interventions. Once nutritional risk is identified, timely support is key. Oral and enteral supplementation are common strategies depending on the patient's condition. For patients with poor appetite or intake, consider high-protein oral nutrition. Supplements O and S. Brands like Glucerna for diabetics or Boost High Protein can provide calories and nutrients needed for healing. In cases of advanced pressure injuries, supplements enriched with arginine, glutamine, and omega-3 fatty acids are particularly beneficial. Arginine supports collagen formation, glutamine helps immune function, and omega-3s reduce inflammation. When oral intake is not feasible due to dysphagia, surgery, or altered consciousness, enteral feeding via nasogastric, NG, or percutaneous endoscopic gastrostomy, PEG tubes can deliver complete nutrition. For patients with high exudate wounds, fluid, protein, and electrolyte losses may be substantial, requiring tailored support to replace these deficits. Always collaborate with a registered dietitian to determine the most appropriate route, volume, and formula. Our nursing role is to monitor tolerance, prevent aspiration, and track intake and output closely. Nurses are at the heart of nutritional care and wound management. Here's how we can make a difference. Screening and referral. Use tools like MST or MNA during admission or rounds. Identify red flags like weight loss, low BMI, or reduced intake. Monitoring intake and healing. Keep track of meal consumption, calorie counts, fluid intake, and wound progress. Document all changes to inform the team. Patient education. Counsel patients and families about the importance of protein, vitamins, and hydration. Share practical suggestions like protein-rich snacks or smoothies. Team collaboration. Work closely with dietitians, speech therapists for swallowing issues, pharmacists for supplements, and physicians. Documentation. Ensure that all nutritional assessments, referrals, education sessions, and interventions are clearly documented in the patient's medical record. Your timely observations and actions can bridge the gap between diagnosis and healing. Education is a critical component, especially as patients transition to home or long-term care. Encourage small, frequent meals rich in protein and calories. Recommend easy-to-eat, nutrient-dense options like eggs, Greek yogurt, cheese, or peanut butter. Discourage reliance on processed sugary foods that may offer calories but lack healing nutrients. Teach patients and caregivers how to read food labels, focusing on grams of protein, presence of vitamins like A, C, and zinc, and serving sizes. Hydration is essential. Recommend 30 to 35 milliliters of fluid per kilogram of body weight daily, unless there are fluid restrictions due to cardiac or renal conditions. Reinforce the importance of early nutrition interventions, post-surgery or injury. Delays in nutritional support often lead to preventable complications and slower healing. Tailor education based on the patient's literacy level, cultural preferences, and home support. Use visual aids, handouts, or dietitian consultations as needed. In conclusion, nutrition is not just an add-on, it is an essential pillar of wound care. Each stage of wound healing depends on adequate calories, protein, and micronutrients. Malnutrition can delay progress, increase the risk of infection, and lower a patient's quality of life. As nurses, we are in a prime position to assess, intervene, and educate. By integrating nutritional screening into our assessments, advocating for timely dietitian referrals, and reinforcing dietary goals with patients, we can make a significant impact. Remember, healing starts from within, and nutrition is one of the most powerful tools we have.